questions. Thank you, Q, again for asking me to talk. Today, you've had a talk on the skull base done by Nigel, a fantastic talk. Let's move on a bit lower down to the neck and larynx, which we do a lot of these days. Again, going back 17 years, I think I've been a consultant here. When I started here, we hardly did any neck MRIs, and today we do them regularly, 5 or 6 per week, I think, or maybe more. And it has become standard for cancer care, particularly of the throat and larynx. It's a very practical talk, and please feel free to interrupt and ask question me about things that I say, which is different to your local practice. The types of scans we use to image the neck are ultrasound, CT, MRI, and PET-CT. Ultrasound, I'll discuss each of the modalities and a little bit, but you've got dedicated talks on them as well. Ultrasound is a good test for screening for neck lumps, and it is now being used in many hospitals for the one-stop neck lump clinics. Ivor, I think, might be speaking today. He's our radiologist who does the neck lump clinic with Q, and it's taken some time to get it set up. And I'm really pleased that he does it, because it really is ultrasound is a really good screening test. So GP refers for neck lump to the neck lump clinic. Ultrasound is done first. It helps to confirm or exclude the presence of a neck lump. Radiologist is able to determine whether the neck lump is of thyroid origin, salivary gland origin, a lymph node, or whether it is indeterminate. Most of the time, it will be one of the three. Very rarely do we get something that is indeterminate. And this is the differential diagnosis for the radiologist. So it categorizes thyroid into benign, suspicious, or indeterminate, to say whether it's a salivary gland, lymph node, or is it none of the three and therefore is indeterminate, or something else that they can come up with a diagnosis for. At the ENT clinic, you might have the surgeon making a decision whether to proceed with an FNA, but I think Ivor will give you, this has been a recent development for us, where Ivor does the FNAs and based on what he finds, and there's a good relationship between the neck surgeons and Ivor, and FNAs are done by him. And then, or to proceed with MRI or to proceed with surgery in the first step. So this is really, the ultrasound becomes a really good tool to help you manage your patients in clinic if it is done before you see the patient in clinic. And I would recommend that as a really good standard of practice. This slide shows a homogeneous parotid gland, and that's when you scan the parotid, it really looks like that. It's really nice, homogeneous. And then you have a submandibular gland that looks like that. Again, it's knowing where your probe is, knowing where the salivary gland is, and finding the echogenicity and identifying the structure. And that is the 2 lobes of the thyroid gland. And that's your trachea. But the trachea contains air, so it produces that shadow that you can see. And then the thyroid gland is wrapped around the trachea, the right lobe, the left lobe, and the isthmus out there. So that's just the anatomy. And this is the neck vessels. You've got your carotid artery and jugular vein. And the jugular, you can differentiate between the vessels. It's where you're putting your probe, and you can differentiate it because the vein will collapse when you press with the probe, whereas the artery will remain bobbing, and you can see, if you put your color flow, you can see the color flow of the vessel. So we'll move on to the main investigation of choice in the neck. I talked about CTs of the neck for emergencies. When you're characterizing lesions or you're doing staging for the neck masses and neck tumors, you use MRI. So it is where are we using MRIs? If it is a suspected pharyngeal or laryngeal cancer, we've seen an ultrasound in the neck and we think it is metastasis and it's an unknown primary, then we would use MRI. And also I use it for if the ENT surgeon is worried that there might be underlying malignancy, although nothing has shown up and the patient's very, very symptomatic, then we would do an MRI. Ultrasound shows a neck mass, and we characterize it with MRI. Ultrasound shows a parotid tumor, and we do an MRI to look at the extent. We'll go through a lot of slides, and we also discussed this morning that it could be used for location of salivary gland calculus. Again, I'm quite happy to do MRIs for all these reasons, but you might have some radiologists who will have a different level of threshold for accepting MRIs. Just to talk about MRI sequences, the main thing to look at is on T1, the two main sequences we use are T1 and T2. Water is dark on T1 and it is white on T2. And then the other sequences that we commonly use are fat saturation to saturate out the fat, and which is very good for looking for lipomas, or we enhance with gadolinium to see the degree of enhancement, and especially for tumors, it might show them up better, or to characterize lesions. I mostly use it for characterization of lesions. So this is to just show you some anatomy so that you familiarize yourself. This is an axial plane at the level of the nose. These are the maxillary sinuses. That's your nasopharynx that you can see the fossa of Rosenmuller on either side. So then we go a bit lower down. This is now the level of the oropharynx. You can see the tonsils on both sides. That's your airway. That's your tongue in front. And you can see the pterygoid, the masseter muscle, and then the medial pterygoid there. So as you go further down, you start seeing the submandibular glands there. You've got your carotid sheath with the vessels, and you've got your tongue base and the vallecula on either side, and that's your epiglottis going there, and your piriform fossas appearing. So when you go further down, you can see that that's the aryepiglottic folds there, that's the piriform fossa, and your strap muscle is appearing out there, and that's the thyroid cartilage on either side. And even further, that's the level of the larynx, and you've got the strap muscles there, that's your arytenoid cartilage there, and your cricoid on posteriorly. And that is subglottic, and into the trachea, you can see your trachea, you can see the thyroid gland. So the anatomy is very well depicted, and then this is, as you can see, the previous scans were all, as you can see, this is T1 because that's CSF surrounding the brain, and it's dark in color. And if I quickly go through, these were T1 weighted images, and you go into T2, where you can see the CSF surrounding the brain is white, so it's a T2 weighted image, and that's your tonsils there, that's the soft palate going across, and you've got your the lateral pterygoid, medial pterygoid, that's your mandible, and that's your parotid gland on either side. So the anatomy is really, really well seen on MRI. Here you can see the submandibular salivary gland, and within the salivary gland you can see really good anatomy of the the duct system. So that's why I feel that MRI is really beautiful for anatomy, and so I feel that it should be used more for problem solving. And I'm quite happy if an ENT surgeon comes to me and says, we're struggling with this patient, can you give us more information? Lymph nodes. So when we're evaluating lymph nodes on MRI, we're looking at three main characteristics: size, shape, and signal. So here you have normal lymph nodes. Here you have a slightly bulky lymph node. So we're evaluating them, and you start seeing lymph node with signal changes. This has got high signal area within it, which is because it's got more water or fluid in it, because it's necrotic, and therefore it's likely to be malignant. So, and on the other side, you will see these are homogeneous, gray, tiny nodes. So you've got a size, increased in size, change in signal, more rounded in architecture. It's likely to be metastatic on the right side. So when we're using, we use MRIs of the neck as standard for cancer staging. And it is to look for local extent, lymph node metastasis, but for distant metastasis, we use a CT or PET-CT. A CT we are using for generally T1, T2 weighted tumors. We may do a CT again. It's discussed at the MDT. For T3 and T4 tumors, we are now more and more using PET-CT. PET-CT is a really good tool for metastatic disease evaluation and to assess the volume of disease but the anatomy and that you get, the local extent that you get with MRI is far superior to PET-CT. So for local staging, we still use MRI. So here is a tumor of the oropharynx, and you can see that that's a tonsillar tumor. The lateral pharyngeal wall, which is normal on the left side, is actually breached, and you're seeing tumor go into the parapharyngeal space. Patients get trismus if the pterygoid muscles are involved. So it's important for us radiologists to comment. That's the medial pterygoid, and you can see that there is no edema in the medial pterygoid. It's as black as on the other side. So there's no pterygoid muscle involvement, but it is extending into the parapharyngeal space. So this is how we do the local tumor assessment. And here you can see we've gone anteriorly, and we're in the tongue, and you can see the tumor is invading into the tongue muscles. So this makes it, I think, a T4 tumor, whatever we discuss at the MDT before we will make the judgment and measure it as well. And again, you can see tumor involving the tongue. And so it's likely to be a T4 tumor. So that was local tumor for the primary tumor staging, and we're looking for lymph node metastasis. And yes, there is a level 2 node, which is enlarged, has got a change in signal, and it is rounded. It's likely to be metastatic. So we'll measure the number of nodes, and we see it's only unilateral, and then the end staging N2 is made. So this is a piriform fossa tumor. You can see the left piriform fossa, the right piriform fossa is collapsed. This is bulky, and then and you can also see that the true chord is slightly bulkier than the false chord. Than the other side. And if we and this is the vocal cord tumor, and you can see a fleshy mass again on MRI. It's very beautiful, and you can see that it's going into the anterior commissure. So local staging with MRI, the anatomy, the depiction of anatomy is great. For thyroid cartilage, for vocal cord tumors, we're also looking for thyroid cartilage involvement, and if there is a signal change in the thyroid cartilage, we assess, we would say probably T4 tumor, and also a strap muscle involvement. And again, these are very well, so local staging for nasopharynx, oropharynx, hypopharynx, and larynx should be done with MRI. And here you can see a very bulky tumor involving the thyroid cartilage and breaking through the strap muscles and involving the strap muscles, and it's outside. So the anatomy is really well depicted for staging, local staging. Unknown primary, the ones that I have seen in my practice come from tongue base, piriform fossa, and tonsils. Sometimes we still, despite MRI, we still don't see it. If there is an unknown primary, current protocol is that if it is unknown primary on clinical assessment and on MRI, it would still go to PET-CT, and occasionally we picked up a tumor on PET-CT within these areas. But it is a clinical unknown primary, do an MRI, still an unknown primary, definitely PET-CT. Okay, so that is how we would go about it. Continued clinical symptoms, because I have a good working relationship with the head and neck radiologists, head and neck ENT surgeons, that if they fill out a card to say we are worried, we can't find anything, I'd be more than happy to do an MRI if the request is from them. I wouldn't do it for a geriatric physician for that matter. So they'd need to see an ENT surgeon because I think there needs to be a specialist review. So here is one case which we had, and this is a real case where there was continued symptoms, and this was early days where the patient came back, I think, a few months later, and then there was nothing to see on clinical assessment, and then you can see there was tumor in the piriform fossa and the thyroid cartilage is involved. So I'm very happy, and these are the same. I'm very happy to, and you can see that the tumor in the vocal cord there. So with continued symptoms coming from an experienced surgeon, I think we should be doing the scans, but we need a good working relationship, and that's where the teams with the surgeons comes in. So we also use MRI for characterization. The pathological diagnosis that we as radiologists can make before even it is taken out is lipoma. The other ones, majority of it is educated guess. A pathological diagnosis is not possible in majority. Distinguishing between tumor and inflammation can be difficult. Again, it is an educated guess based on how is the patient presented. Is it acute presentation? Is it a chronic presentation? Are your inflammatory markers raised? So for radiology, it's a mass. It's an enhancing mass, both tumor and inflammation enhance. So there is no distinguishing factors apart from how the patient has clinically presented and what is the likelihood, pre-radiological likelihood of what it is. So just a few pointers on what do you get with T1 signal and what we're looking for when we are trying to characterize. T1, high signal on T1 we see with fat, blood, contrast, calcium, and melanin, which are rare. But the main one that we're looking at is fat because we're trying to diagnose lipoma. And low signal on T2 we see with blood, fibrous tissue, inspissated mucus, air, sclerotic bone, and calcium. So these are the, and this is a comparison we talked about, and you can see a really nice, when you're looking at images yourself, try to find the brain, try to find the CSF. If it is dark, the CSF, sorry, my pointer's going all over the, so if it's dark, the CSF, it's a T1 weighted image. If it is white, the CSF, it's a T2 weighted image. So this is just for you to, when you're looking at MR images by yourself. So here you can see, this is T1 weighted images. The CSF is dark. You've got a bright lesion there, which is asymmetrical. When we get a bright lesion, we're thinking, is this fat? Because you can see subcutaneous fat also is bright. And then we do a fat saturation, and it loses its white signal. That's a T1 with fat sat. That's a lipoma. So we make a diagnosis, and we're never incorrect about a diagnosis of lipoma. And here is, this is actually a CT scan, but you can see a laryngocele. You can see that air tracking outside of that's the level of the piriform fossa and the airway, and it's tracking outside into the subcutaneous tissues of the neck. So that's a laryngocele. This was an interesting case many years ago, a posterior pharyngeal wall soft tissue mass. Didn't know what it was. It was thought to be a lipoma on clinical assessment because it was very smooth, and when you went into the mouth, you could see this bulging soft tissue. But as you can see, it's not got high signal on T1. This is T1 weighted images. It's not. It's kind of dark. It looks like soft tissue. And what I said to them was that it definitely isn't lipoma. It was extending lower down to the level of the piriform fossa. As you can see, that's the piriform fossa, if you've got the anatomy by now. And then on T2, it was a bright signal. I didn't know what it was, but what I did know was that it wasn't a lipoma, because that's a diagnosis I can make on imaging, on MRI. And we gave it contrast, and it enhanced. Again, that doesn't tell me anything more than pre-contrast, my opinion. It was taken out What I could say, however, was that it looked benign because it's got no infiltration, it's got a nice capsule surrounding it, and it looks very, very benign, not like the tonsillar tumor that I showed you earlier. So they took it out and it was a schwannoma. And I don't think I could have made that diagnosis other than saying it's a soft tissue tumor, looks benign, and it's not a lipoma. So these are the three things that I could have said, and I don't think I could have made a pathological diagnosis. We need to keep the pathologists in a job, after all. So, and again, if you look at now a different case, and it looks very similar to the previous one. So it's a posterior pharyngeal wall mass, and you can see it extending down on T2, and it's there. Again, it looks very similar. This is post-contrast FAT-SAT, and it's enhancing the walls. It's got less homogeneous enhancement than the previous one. However, this one actually I made a diagnosis because I saw this, or I made a provisional diagnosis. I wasn't wanting to be absolutely certain because they were really odd. And that's this tongue of tissue that goes to the thyroid gland. And I thought this was a multinodular goiter that was placed in the posterior pharyngeal wall, and that's what it turned out to be at surgery as well. So other neck masses, Nigel talked about, this is a glomus jugulare. It's at the carotid bifurcation, and it looks, again, soft tissue density on, not density, but soft tissue signal on MRI. It's very similar to the muscle that you can see there. But what it has, it's got these small flow voids, and that's the giveaway sign of it being, and its position, that it's here it's like, this is the carotid bifurcation, and you can see it's lying just behind the carotid bifurcation, and it's got these flow voids. So this is a glomus tumor. And this is another glomus tumor, but in a different position, jugular tympanicum. And again, it's got this tiny flow voids. And the ENT surgeon was suspicious of it because they could see a bluish tinge there. And so you can see it there, and we gave contrast, and you can see here how it brightly lights up. So that was the diagnosis. So here is a CT scan, and you can see this is another neck mass, but it doesn't have any enhancing walls. The vessels have lit up, but the sides, these walls, that's a branchial cyst. So, but always be wary of branchial cysts, because the branchial cyst that I've very rarely seen a branchial cyst, but the clinical query about branchial cyst more often than not have been a cystic lymph node and a necrotic lymph node. So just be wary what we're dealing with. It has been the case where I've said, no, this doesn't look like a benign branchial cyst. It has structure, soft tissue material within it. I'm concerned about malignancy. And even though the aspirate was benign, when it was actually taken out, it turned out to be a malignant node. That is where, we need to work with ENT surgeons and say, look, we're not happy. And then they are willing to take it out and say, yeah. So you've seen this slide before. No, not this one. So here is a mass in the, I think this was a lymph node mass there. And what I also found, so that was the lymph node mass. That was a tonsil that is enlarged. And then when I went further down, there was this thyroid gland that is enlarged. And then we go further down, and there are mediastinal nodes. That's a lymphoma. Now, again, I can't tell. Histology tells me it's lymphoma, but I guessed it with so many multiple areas that are involved, and it's going down into the mediastinum as well. But we need histology. So this is another interesting case where there was some bulging in the post-cricoid region there. And you can see the speckled calcification of the cricoid cartilage. And this is a benign It's called a chondrosarcoma of the cricoid cartilage, but actually it's slow-growing benign in elderly patients. But I don't think the surgeon wanted to do anything, but it was a diagnosis we made with CT. So let's move on to salivary glands, which are also part of the neck. And the four questions that a surgeon is asking me is this a salivary gland tumor, lymph node, or other? What is its extent? Is it just in the superficial part or involves the deep part as well? Is it multiple or single? And is it benign or malignant? And the last one, again, as I've told you before, we're still keeping the pathologist in a job. So we don't tell you whether it's benign or malignant unless we can see lymph nodes. So if we see a mass with lymph nodes in the neck and it's slow growing, you've told us that it's not an acute presentation. We know this is malignant because benign tumors would not have lymph nodes. So it is an educated guess in a way. So here is the salivary gland tumor. And we've confirmed that it's in the parotid gland. So that's confirmation and that's the T2 weighted images. Single or multiple. So here you can see that's a single, and here you can see there are two of them. So that's multiple. And you're obviously thinking, can I differentiate between Woden's tumors and pleomorphic adenoma? No. So, but then your guesswork would be if it is multiple, perhaps Woden, but you still need the pathologist's help for that. Extent, this is within the superficial part of the parotid gland. Your retromandibular vessels are there, so it's largely superficial. And on the other side, you can see it's going into the deep lobe. So that's what we can tell you, and that helps you plan your surgical time to make sure that if you've got a deep lobe extension, you can say, I'll need more time for surgery. Benign and malignant, that actually turned out to be malignant. This is post-surgery, and that is recurrence there, and that is benign. Now, radiologically, without any lymph nodes on either of them, it's very difficult to tell. They'll both enhance, so you can give them gadolinium if you want, but it's not going to make a difference. What you need is a pathologist to tell you whether this is benign or malignant. So let's move on to use of CT in the neck or neck-related things. We use it for chest staging, as I talked about. We talked about neck abscess in the previous talk, but we'll also look at it here. Again, as I said, MRs, for acute patients, CT is better because it's literally, the patient is scanned within a minute. Nowadays, the scanners are so quick. So they put the contrast, they start the scanner, and within a minute, all the images are acquired. MR takes at least 30 minutes to acquire a neck imaging. So 1 minute versus 30 minutes. Acute patients find it very difficult to lie on the scanner for that long. So when you're making a judgment call of what imaging modality to use, for acute inpatients and A&E patients, CT is the modality to choose. For cancer staging, I think MR is the gold standard for local staging of tumors. So we're using it for bone assessment, temporal bone imaging, and sinus imaging, which people will talk to you about. We're using it for emergencies and neck abscess evaluation, and we're also using it for the CT for chest staging. So here you've got the neck abscess that we discussed before, and then you've got a prevertebral abscess from acute tonsillitis. Again, we used a CT scan there. And a synchronous primary when you've been scanning somebody as part of your staging process, and you find a synchronous primary in the lung, and these patients will be then referred to the lung MDT for further assessment. PET-CT, when I started talking about these, we were hardly using PET-CT when I started doing these talks here, but we're using it more and more. At least we'll have 1 or 2 PET-CTs to present at every MDT nowadays. Most of our T3 and T4 tumors on neck MRI will have a PET-CT rather than a CT scan. And we discussed the unknown primary, which also go through PET-CT. And occasionally we do find PET-CT picking up tonsillar tumors, which are not visible on clinical assessment, not visible on MRI, but are actually picked up on PET-CT. So, and also it can be used for recurrence assessment. And this is another place where it is being used a lot more. But you need to be beware of pitfalls of PET-CT, because again, like all imaging modalities, often we can't differentiate between inflammatory process and tumor on PET-CT as well. So these are some images that the kind of images we get on PET-CT, and this is PET-CT showing the radionuclide uptake on a piriform fossa area epiclotic fold tumor. For me, it is all about team working with you all. Build your teams with your radiologists, and I think you'll get the best service if you actually build the teams with us. And we find it good to get the feedback, get good referrals from you, which tells us what you require of us. So it's a education on both sides. So that's my view anyway. So thank you.